Good morning. It's May 11th and it's 11:32 a.m. This is a joint Behavioral Health and Legal and Justice Subcommittee of the Incarceration Reduction Task Force. We'll call the meeting to order with the land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. I'm going to go straight to the next topic on the agenda, which is Ann Deacon on the behavioral health section.
I'm the behavioral health section, or am I doing the presentation? Jill? What's my role here, Jill? I'm sorry.
Sorry, let me pull up the agenda. Let me look at the agenda again. Update on the Behavioral Health Crisis Response Expansion Program.
Okay, so if you don't mind giving me the ability to share my screen, I'm going to zip through this since some people have seen this, but I just wanted to give a brief overview of the planning that's been taking place and the action steps that are planned.
You should now have sharing ability, Ann.
Great. So, is this showing for people now? Great. All right. So there has been a request first from the City Council to look at alternative responses to law enforcement response to people who are experiencing behavioral health crises. And so the health department facilitated some efforts here to gather together people to work on this effort. And that included quite a few folks. We were looking basically to see, is there something we could do to reduce law enforcement responses safely, which is number 3, to improve our outcomes for people experiencing behavioral health crises, and to enhance integrated systems of behavioral health response and support. And so the people that have been participating in this program are city and county council members, Bellingham Police Department, Sheriff's Department, Bellingham Fire, as well as EMS, dispatch from both Whatcom and Prospect, and treatment providers as well. And then also the mobile crisis outreach team that already does some of this work, Grace, who does some of this work, and then County Human Services. And part of this was data collection from dispatch and law enforcement, which was incredibly extensive, hundreds of pages of data. And then some qualitative work as well to look at people who are in the system, what are their experiences. And then some of the data that was quantitative that we looked at, and which I think is really important for us to consider here, is that the behavioral health calls to 911 equaled about 11% of all calls. What we also heard anecdotally from officers is that 80 to 90% of their 911 calls involve a response to someone with a behavioral health issue. But what we understood as we kind of delved into this further is that that overgeneralization certainly didn't imply that we should not have law enforcement respond. So obviously when there is a crime involved or the potential for harm, then law enforcement will respond. And that some people who have a behavioral health condition may not necessarily see any improved outcome in that particular intervention just because a behavioral health professional is there. And we can get into more of that later. That's a lot of detail, but just to give you some background there. But here was the thing that really made us realize that we need more data. Only less than 35% of the behavioral health calls, which is just 983 of them, started as behavioral health related calls and ended as such. So that was less than 4% of all law enforcement calls, or less than 3 a day. So there were two things. One, how many of these really will not be relieved by having a non-law enforcement team respond? And secondly, how are they being coded in the first place? Two really critical things to look at. And the other thing we knew we had to look at was that mental illness is an equal opportunist, which means that it impacts people who have criminal intent and behavior, and it also affects people who are law-abiding citizens and residents. So for us, just because someone has a mental illness doesn't mean that law enforcement should not be involved. We also then knew that the low predictability of those 911 behavioral health calls made us realize how important safety of any team responding is, and that we've got to look into that further, and that data gathering and analysis is going to be critical here. And so in order to do that data analysis further, we realized we needed to have a phase 1 of this alternative response model. So phase 1 is really creating a co-responder model with Bellingham Police Department so that we have a behavioral health professional teamed up with law enforcement to actually start to gather data on the calls that appear to be behavioral health related, help us figure out which of these do we think are needed to, oops, I'm moving my camera here. Which of these are truly more appropriate for an alternative response team? What are the characteristics? How would we help dispatch understand and identify those? So a lot of this work in phase 1 is really to help inform dispatch to feel as confident as possible that they're not dispatching a team and placing them in harm's way. And then the phase 2 would actually be creation of an alternative response team, which would be at this point out of the prospect arm or the EMS side of the house. And it would have an EMT and a behavioral health professional. This is similar to some other programs. Health One in King County, for instance, is one that does it this way. The difference here that City Council asked us to do was to actually dispatch straight out of 911. And let me tell you what that means. The CAHOOTS model in Eugene, Oregon, or the STAR program in Denver dispatch the vast majority of their calls out of the non-emergency line, not the emergency line, not the 911 emergency line. We actually have a non-emergency line both out of 911, which is a full phone number, but also out of our care crisis line. Both of those can dispatch, and our care crisis line dispatches the mobile crisis outreach team often. So it's not that we don't already have a non-law enforcement response to behavioral health people, to people in behavioral health crisis. We do. But the request of us was to look at how might we create an actual emergency response out of 911 for an unarmed team. So that is a huge difference. We have not found any other programs quite like that in the nation. Like I said, most of them dispatch out of the non-emergency line. Not that 911 emergency doesn't sometimes transfer the call over and dispatch. The other thing we looked at is, as we start a new program, what would be the hours of operation? We found that between 3 and 4 in the afternoon were the busiest times of the day when people were appearing to have a behavioral health issue or crisis. And so we thought maybe we could create 2 teams, each team working 4 10s, 1 day of overlap, sometime between the hours of 10 a.m. and 9 p.m. The other thing we realized is that we've got a lot of different response programs already. We need to be as unconfusing as possible. And so we would likely bring this program in under the auspices of Grace. And when we were doing all of our qualitative interviews, to a person, everyone said, don't mess with Grace. Grace works. Grace is what we need, don't change it. So this would be a distinct and separate component, this alternative response team. It will not replace GRACE in any way. And then, I should also say that Lake Whatcom Treatment Center received a grant from the federal government to provide some outreach and engagement services. We realized that crisis response alone doesn't go very far, and that it just deals with the intervention at the moment. And so for us, we understood that really to create some long-term stability for people, they needed to be engaged and connected for a time period after that crisis. And so Lake Whatcom Treatment Center is working with us to be that program that provides the follow-up. So that'll be critical. We also looked at an estimated budget for the city of Bellingham if they were to fund this. And this is what you see here. I won't go into too much here for now. And then Whatcom County Sheriff's Department was pretty clear that they did not feel safe with an unarmed response other than the one that already exists with the mobile crisis outreach team. That the geography of the county is such that sometimes it would take a sheriff deputy quite a while to get to a scene if an unarmed team said, "Oh, we need backup." And so for them, they would prefer a co-responder model that would be an enhancement of what they currently have. And there's a program operated by Compass Health called Impact that already has this kind of model in place. So just to add more confusion, but also letting you know all the different moving parts that we're looking at. And then the other thing we really need to understand is how do we make sure that we coordinate with all the current programs in place, put together a seamless program where roles are defined, people know what their role is, they know who to call for what. That takes a lot of communication and planning, but we didn't want to just throw in another service and confuse everyone. So there's a lot of work to be done here. And then finally, the other thing that's really challenging as well as wonderful is that the state legislature passed a bill this session that basically allows the state to use the federally designated 988 number. So the feds recently dedicated 988 like a crisis call line. So even though we currently have a regional crisis line, that entity will probably take over the 988 for our region. And so this will also make a huge difference in that as people in the community learn about 988, they will probably be calling that rather than 911. And then this would be the line that we would dispatch this alternative response team from. So that I think is supposed to go live, 988 is supposed to go live next summer, a year from this coming summer. So again, lots of moving parts for us to factor in. So in terms of our next steps, obviously we are hiring and just hired the position that will be working with Bellingham Police Department starting sometime this next month. We are still vetting our program design further. We're gonna have a big community forum with NAMI, the National Alliance on Mental Illness in Whatcom chapter, to make sure we've heard what we need to. We've also met with the chairs of the Racial Equity Commission to make sure we are being informed about things we don't know. And then the other thing that we really have to look at in all of this is the workforce challenge. We understand, first of all, that law enforcement is experiencing significant shortage of people coming into the field. We also know that vacancy rates in the behavioral health provider agencies are significant. One of our largest providers in the region has over 100 vacancies right now, for instance. So we can design the best perfect program, and if we have no one to stand it up, that will be an issue for us. So those are just situations that we have to take under our belts to figure out how do we move forward given all of these challenges. Exciting challenges, but challenges. So I'll leave it there. That was the Cliff Notes version and the Evelyn Wood reading, speed reading version right there. So questions?
And this is Mike. Thank you for that. First of all, that's great. And I didn't know all of this. So not all of your members today had seen that before. So it was new to me and I appreciate that. I was curious, you mentioned kind of the challenge in comparing data in terms of the number of programs that might actually dispatch a behavioral health responder from 911. You mentioned Cahoots. Is there really just nothing nationwide then that does something similar? I guess I thought Cahoots was kind of similar to that, but it sounds like they do. But you said more calls are coming from a non-emergency number.
The majority of their calls for dispatch come into their non-emergency line. And Denver Star fashioned their program after Cahoots, and it's similar. So yes, I think a number of people thought that Cahoots went straight out of 911. And it's not that they don't. I mean, a 911 dispatch, person may go, oh yeah, this goes to Cahoots. But it was new to us as well and made us really be a little bit more thoughtful about how we design this program. And I don't need to share my screen anymore, but I can't unshare it unless you've done that for me, Jill. Oh, there it is. I see it now. Phew. Sorry.
I think Stephen Goffley has a question.
Thank you, Ann. That was really an excellent presentation. I think one of the things that struck me most and raises two questions is your statistic that only 1/3 of the behavioral health related calls began behavioral health and ended behavioral health. And the implication you drew from that, as I understood it, was that supported leaning away from too heavy an emphasis on an unarmed response. And I guess what I'm wondering is, wouldn't that suggest the validity of some concerns in the community that an armed response might sometimes sort of draw out a violation that then calls for a law enforcement involvement? In other words, might the presence of law enforcement precipitate a law enforcement incident? And I'm wondering if I understood that correctly. And number two, I'm wondering, is there a way that you are set up for post-implementation services that would be able to continue tracking data to answer those questions?
So I think we could infer a number of things from that data point, and we chose not to infer anything because of a couple things. It could be just a reporting issue. And maybe it was behavioral health starting in, but it had a criminal component, which meant that law enforcement needed to be there anyway. Or it could have been that what they thought was behavioral health over the phone really wasn't, that there were many other issues going on and they chose something else. So it could be a reporting issue alone. It could be that the uniform itself caused a different response. I think, I'm always careful about that because there's people in uniforms, right? And I'm not quick to judge just because someone's in a uniform that they don't have the skills to manage a situation, because in fact, we've got our grace case managers work with law enforcement, both sheriff and Bellingham Police Department, and rave about their ability to de-escalate and show a lot of compassion. So, so for us, all that meant is we have a lot of research to do, a lot of data collection and analysis, and we need to do it on the scene so that we can truly inform dispatch. Because we just didn't want to go by what our preconceived notions were. That's not good science.
That's super. So you're set up to start gathering and analyzing that data as you go.
Yes.
Fantastic. Fantastic. That seems the right approach.
I see Bill Elfo, Sheriff Elfo.
Yeah, I just wanted to add there may be a new dynamic in this whole situation. The legislature passed a new bill that will take effect in July that limits law enforcement's ability to be even present if there's not a crime or there's not an imminent threat of danger. We're just digesting this as it's come out, and we haven't had a chance really to talk to our legal advisors at the prosecutor's office, but that's another potential factor in what law enforcement's response will be, whether it's the county or the city, I would imagine.
Thanks, Bill. And you know, that's Senate Bill 5476 that has all those different requirements in it. And in a webinar I attended last week that Senator Dingra, who was one of the sponsors, was present, she said, she was very clear that she thought law enforcement shouldn't be asked to act as behavioral health providers, that law enforcement should do law enforcement and behavioral health providers should do behavioral health. I think on paper that's great, but in reality, you know, we just don't have those clear boundaries. So I think anything we can do to, you know, have the right people respond is what we're going to have to do. And that's what our research here will be telling us. But I don't think we throw the baby out with the bathwater.
Thanks.
Arlene, I see you.
Thank you. This is wonderful that we're going in this direction. It's definitely what most of us want to see happen, that we have the appropriate response to what's going on. So thank you for all that work. I know it's got to have been really difficult. At the same time, I have a couple of concerns. One is that I was told quite some time ago by Chief Dahl that 80% of the calls are behavioral health related. That's not evaluating it, but that's the beginning of the evaluation process. So it's crucial that the dispatchers are very finely trained, as well as the first people on the scene. The second part that is a concern to me is the hours of not having coverage. This is a program that needs to be 24/7 in order to be effective, because much does go on during the middle of the night. And I don't want to see a partial program. So, I mean, what do you think about what I'm saying so far?
I think in listening to Cahoots talk about their program, they operated for 25 years before they were able to go 24/7. And that with our workforce shortage, we're trying to work with reality. Do we think it'd be great to have 24/7? Yes, absolutely. But if we don't, then we had to look at when was the most active times that would, you know, best use what little resources we have. So I don't disagree, Arlene. I just, if I implement a program, I actually have to implement it. So, and I need people to do it. So that's been our biggest challenge these days, is just not enough people in the workforce.
Well, I'm sure this has been said to you many, many times, but the thing that attracts people into the workforce is salary. And then maybe we need to look at bumping up our salaries into a level that will entice therapists to come into our beautiful lifestyle community and work.
No argument from me.
Thank you.
And I have a question, and it kind of goes into number 5 of the workforce shortage of behavioral health service providers in the community and how to attract personnel. I mean, I think the two are linked in reference to this program, because I don't think there's enough providers out there. I have concerns due to Western states, because I've heard unless it's a court order, it's hard to get people in there. I don't know how accurate that is, but it was due to a recent individual that needed to be committed. I'm seeing more people that have been out, restored, and then are back in the system on a regular basis. Is that because of the shortage or not enough facilities to keep these people? Where do you stand on that area, and is that going to impact this program?
If someone in our county is involuntarily committed under the Involuntary Treatment Act, beyond that first 72 hours, they then must go to an up to 14-day stay. So for up to 17 days, they can be treated in the community. After that, if the Involuntary Treatment Act still kicks in, then the next period of time is up to 180 days. And at that point, the state hospitals must take those folks. As you know, there's not enough room in the state hospital for those folks. And so the state is putting out grants to different agencies willing to build a behavioral health facility that will serve those longer term people who have been civilly committed in local places. But the other end of that is sometimes somebody is released on a least restrictive order, which basically means they're committed to treatment, but on an outpatient basis. But there are no openings right now in any behavioral health agency locally for them to be under the treatment of. So even though they might be on a least restrictive order and need to have a therapist, doesn't mean there's a therapist available. In fact, there isn't. So we have great difficulties on the front end as well as the back end right now because of the workforce shortage of behavioral health folks. And the state, as you probably recall from a couple of years ago, was fined in a court, and it was a Supreme Court, a state Supreme Court order where it was the True Blood lawsuit, I'm sorry, that basically commanded the state to provide enough services and access to stabilization and recompensation. And they're doing what they can, but again, they're not meeting their needs either because of the workforce.
Mike Barker has his hand raised.
I feel like I'm depressing everybody here.
Go ahead, Mike.
Thanks, Raylene. Thanks again, Ann. And no, you're not. I think we're just we're diving into some of the pieces. You know, I think that's a good thing to highlight is that we're getting some new assets here. And I think what I'm hearing from you a little bit too is that it's going to be a little bit of design build. Like we wanted, you know, the full cruise ship, and we have a smaller size one, but we're still going to have one. So I appreciate that. I appreciate the flexibility and the creativity to launch something, and then to get the data as it comes back in, and then make adjustments. I also love that we're going to be able to expand. You know, in Eugene, my understanding is that Cahoots is in Eugene and not necessarily in all of Lane County. So the fact that that at some point a co-responder model in Whatcom County, as rural as we are with our sheriff's department, is amazing. So let me highlight the win and tell you not depressing. I wanted to just really quick go back to data, because you brought up some really, in the beginning of your presentation, it talks a lot about the data, and that shapes our program creation. And it also, it can tell us how well we're doing or how much of an issue. And I just know my participation in this committee, without the data from law enforcement, we wouldn't know how well or bad we're doing. And it's been amazing thus far to have what we have. Does it make sense, or is the way that our dispatch is now and how we're capturing information? Arlene, you got at this point a little bit when you said, you know, those folks are going to need to be highly trained in order to figure that out on a call. And I don't even know what that looks like. But I guess I wanted to get at that data question. Do you think that the structure is necessary to track that data, both about when we dispatched using our new either that be a co-responder model in the sheriff's department or the program in Bellingham? do you feel like we have the data that we need to know now to be able to, do we have the structures in place? Is the training in place to essentially kind of capture that? Or would you also describe that as kind of a design build as we go, we're going to further refine? And if you wouldn't mind, just touch on any pieces too. Are we capturing those demographics about folks? Because I think that's another key thing we want to make sure is that we are capturing all the things you mentioned. You talked to the Racial Equity Commission designers, and we're curious about that as well.
So we have an entire parallel process of putting together a training program, not just for the first responders, but that to include law enforcement, EMS, behavioral health responders, also the general public in terms of how to access the services. And then obviously all of it to inform dispatch and to train dispatch. Dispatch has been fabulous. They have opened all of their data to us. And we have a data nerd who has spent hours and hours and hours going through it and then going through it with us. So I feel like we know what we know, but what we don't know is what they don't collect. So demographics, they don't collect particularly. We don't collect what does a behavioral health call mean, because that's subjective right now. So there's a number of things we don't collect that we're adding into the data profile of this phase one, so that we ask ourselves the right questions, which is why we're talking to some of the people we're talking to, including this upcoming NAMI forum, which hasn't yet been scheduled, but we're in the planning process. We need to know what we don't know. And sometimes if we don't talk to the right people, we don't ask the right questions.
Thank you, Anne. I believe Stephen has a question.
And you're on mute, Stephen.
Sorry. I want to start first by echoing Mike's appreciation of the care and the progress that you've made and the thought that's gone into this and the things you've highlighted that still need work. So as usual, it's a really professional approach to this, and I'm quite hopeful of the progress that we're making. I want to go back to the workforce issue. I too see some overlap between your comments, Anne, and the agenda item a few items down, but I also think they're different. And so just as an informational point, what would be the minimum qualifications for a behavioral health responder in this kind of unarmed response? Is it a bachelor's plus a couple years experience? I assume it's not a master's level clinician like might be talking about in item number 5 below. I'm just wondering where we might be able to attack that limitation that seems to thread throughout so many of the reforms we're discussing.
Well, obviously, we've been looking at that qualification standard in some of the other programs. Cahoots, for instance, doesn't even require a bachelor's level necessarily, but if they don't have a bachelor's, they at least need an associate degree with 500 specific hours of training, for instance. So I think we're still going to be figuring that out. The person that has been hired to start phase 1 is a licensed master's clinician. So I think that will help us in the data gathering, just a little bit more sophistication there to know what needs to be asked, and how do we format this so that the right skills come to the table. We also know that, just as someone in a uniform may or may not have good social skills or emotional intelligence, same is true for behavioral health professionals. So we know that even a master's degree licensure doesn't ensure that they are skilled at de-escalating someone, right? So for us, part of it will also be what are the skills needed to do this job successfully, and how do we screen for that? Very challenging when it comes to some of those soft skills. Other questions? So we're moving forward. We'll launch phase 1 next month. I think we were kind of looking at a 3-month period of data collection. We hope we'll get somewhere with that and hope that's enough. And then we will move forward from there. We'll also have to talk with the city of Bellingham in terms of how to fund this program, and lots more to come. And then, as the sheriff was saying, all the new laws that are coming into effect on July 25th relative to this, plus the 988 phone number next summer, are both challenging as well as hopefully helpful in some ways.
Moonwater?
I thank you so much, Anne, for sharing that overview. And I'll just throw out there that as these programs develop and more staff is brought on, I'd welcome the opportunity to support onboarding and training in the short term, long term, through the resources that the center has to offer, through our current training offerings or custom training, just to support that interest-based approach to de-escalation and supporting the whole person. So
that'd be wonderful.
Chat separately, but know that offer and desire to help is there.
Really appreciate that. Thank you, Moonwater.
Thank you, Anne, for the overview. I do have one quick question, is when we're going at data collection as we're moving forward, if a behavioral health responder comes across something or there is a victim, will we be tracking the data if it's turned over to law enforcement?
Yes. Because we also need to know when did we have the wrong response, and why do we think it was the wrong response, and how do we guard against that in the future?
Thank you very much. Is there any other questions?
I have a question. This is Heather. I'm sorry if you went over this, Anne. I just want to be clear. You were talking about the data around what actually is truly a behavioral health only call. And you were saying that if there's an element of crime, a crime committed, or a safety concern, those would be the two things that would require law enforcement presence, right?
Definitely, yes. There's probably something else too I don't know about. I'm not fully informed about law enforcement, but there are times when, yes, they must respond.
Right. I would love more understanding around those pieces, I guess, especially the safety piece. And because I guess I have questions about, like, how are we defining safety? And is it, in my head, I'm thinking about, are there situations where law enforcement presence has escalated the situation to where there is a safety concern, or and maybe there wouldn't have been if law enforcement wasn't present? And maybe I'm overcomplicating it, but that's kind of where I'm thinking about what's our definition of safety and more understanding around that.
So our initial definition is that if there has been an assault or a threat of an assault, that would be law enforcement.
Mm-hmm. That's helpful. Thank you.
And I have a question really quick. Just wondering, when you've looked at Cahoots and other programs, have you found programs that have found successful ways of working with other systems? Like, for example, for our school system, when we look at, let's say there was a response over the weekend or a weeknight, and it was either around a parent of kids that are in our schools, or it was one of our students. And so ways that we could work, I understand the limits of confidentiality and information, but if there's ways that we can help those kids re-enter after a situation, have you seen any examples of that, those kind of inter-system collaboration? Thanks.
So Chris, that's such an interesting question, because almost every program says they do that. And I think in our own programs locally, we say that's our goal and that we do that. Whether or not we're successful, I think, is another thing. And so when we do design our program, I think we've got to be pretty clear about the protocols in place to ensure it happens. Because obviously, when you've got a family involved, it's more than just that one team, right? They might have therapists, they might have primary care physician. Obviously, they have schools. We hope they have schools. Yeah, they might have a behavioral health treatment provider. I mean, just all those things. I don't think that was helpful, Chris, but you know, I see these wonderful things on the websites, and then, you know, you start to interview people and you go, oh, yeah, we already do that. Thank you. Didn't learn anything new. Not that we're trying to be arrogant. It's just that we really actually want to learn something new.
No, I appreciate it. Yeah, I think we're trying to get better at Bellingham schools and working with our resource officer and of course other systems and really trying to move the needle around trauma-informed practices for our own staff and how we can do that better with that, you know, information that hopefully doesn't infringe on students' privacy, but does allow us to care for them better. So any ideas on that, I'm always up for. Thanks.
Yeah, I think we fully understand the trauma that can occur, especially when they have to return to school and pretend that things are the same as they were when they left the Friday before, for instance. Yeah.
Darlene?
Thank you, Anne. That was really helpful. One of the questions that I'm really struggling with is community resources as we keep starting these different programs. I love the programs that we're doing. And I know even here in our court, when we talk about community court or other kinds of things that would address more of the whole person issues as therapeutic courts do, like our mental health court. I guess that's one of the things that's really confusing to me, because I feel like we're pulling our social services in so many different directions with so many programs. We're lacking mental health providers. We're lacking many kinds of providers. Is there something other than money that other communities are doing to try to bring in more people that would bring more resources so that we could keep moving forward? Because to me, it seems like that's one of our toughest areas, is to get people to come in and be committed to these programs. I'm worried that when we keep spreading the few people we have thinner and thinner, that they're going to burn out and we're going to lose them. And so I don't know, is there anything any other community has done to try to do that, Anne?
I would say that I think we're ahead of the curve in terms of when we participate in national calls, as well as some statewide calls. We tend to be ahead of a number of people in this regard. Where I think we could do more is in providing training for people who may be peers or may not yet have a bachelor's degree, and somehow find a way to train, supervise, mentor people who may not need those degrees, but could still be really successful in this work. And I think that's probably an area of focus that we could concentrate more on, and that would help. But burning out our current workforce is a huge concern for us. Even with our behavioral health officers that are teaming with the GRACE program manager, or the GRACE case managers, I think they're sometimes in awe of the burden that those GRACE case managers carry, and the work that is involved in keeping people stable, and to create and establish that village around people that need a village to remain stable. It's just really, really complicated work. It's great work, it's rewarding work, but not everybody can do it. So I think the more we can bring people along and provide the support they need, the better.
This kind of work, you know, this is just my opinion, but many of you are in the field of counseling too, and it's a calling. It's very difficult work, very stressful, and very complex, because you're responding to the immediate crisis of emotion, you know, extreme emotionality usually, and then the possibility that behind that there is a serious mental illness going on and an addiction, which is typical, that there are co-occurring disorders creating crises, immediate crises. So the training of the staff, you know, in my opinion, should be the highest level, because it has the most complex problems to deal with.
One of the questions—
that's not typically what happens. We get people very often just directly out of college without sufficient experience with these kind of situations. I mean, therapists are in situations sometimes where they have to say to somebody, you need to give your knife to your father immediately. I mean, there are situations where you take charge, but you cannot do that unless you have plenty of background and experience knowing what you're going to do and knowing what the risks are.
Well, one of the things that I've been thinking is we have a beautiful university right in our city. And is there a way we could partner with any of those programs? And you were talking about training people that are very interested in the field but may not have their degree yet. Is that something that we might be able to look at? Or I don't know.
The university has a human services bachelor's degree, and they are required to have internships, and a lot of our agencies provide those internships, and it's a great entry into the field. We also, you know, I think I saw Perry Mowry on the call, but he sat on the advisory committee at Whatcom Community College to help people who have a master's degree in mental health counseling to also get on a speedy path to also being certified as a substance use disorder professional. And so a whole new set of curriculum that would help do that as well. So where we see the opportunities, we're taking them. But whenever you do provide internships, then the person who's providing that supervision is not producing income for the agency. So it's another challenge. We just have an underfunded system in our nation. For whatever reason, our nation has never prioritized behavioral health. So locally, I think we do what we can, and I think we do a lot, and I think there's plenty more we don't do and wish we could.
Coming around to the comment and question by Heather, and every of the comments from Chris Cochran and everything I recall an individual that was just 18, high functioning autism, and he was charged with malicious mischief, domestic violence. Law enforcement were called because he continually punched the wall. He was a large young man, and he ended up going to jail because law enforcement were required to put him in jail. And I remember the hearing very vividly because the judge said, you know, do you understand why you're here? And he says, yes, I'm not supposed to hit my sister or my mom. So I kept punching the wall because I'm very angry and I don't know how to control it. I'm sure many of you people that are in the mental health field have heard stories like this, and law enforcement have heard stories like this. And it was so sad and tragic because those of us that were in the courtroom in the jail knew that that young man didn't belong there, but law enforcement had a duty that they were required to fill. The thing that came out of that is he got help because he was put on pretrial monitoring to get him the mental health assistance, and he wasn't convicted as long as he was getting the help. And that's what the family wanted. They wanted to call 911 to get help for their son. Going to jail wasn't the answer, but we don't know that the resources are out there. And I think that brings us again to number 5 is sometimes our behavioral health professionals are so bombarded with the more serious mental health behaviors and drug-induced mental health behaviors that they're burnt out, and we don't have enough individuals. I think the question we need to ask both Behavioral Health Committee and Legal Justice Committee, what can we do as a whole from our task force to bring qualified behavioral and areas so that we have what we need to combat the problem? And what is it that we need to ask for to make this happen?
So let me just say a couple things, and I'll let the committee weigh in as well. So there's a difference between mental health treatment intervention and behavioral management. So sometimes it's a process. What is needed is behavioral management, which a behavioral health professional may not be very good at or may not have those skills at providing. Or with somebody on the autism spectrum disorder, maybe they need some really specific applied behavioral analysis, a chain analysis, which is, again, very, very specific training required and certification. So I want to make sure that we don't use the same tool for all the issues, because different nails need a different hammer, right? So that's the one thing I would say, and that gets really technical, but it's the only way to be successful. And then I also think as a incarceration prevention and reduction task force, we have to be thoughtful about the resources that do exist that can support some of these, and make sure that we don't take from programs that are providing successful outcomes, and just figure out where else we may be able to get resources to support some of the other programs we need to do. It's quite the balance, but I do worry sometimes that programs come before our county council. Rarely does a bad program come before our task force even, but where does it fit in the strategic plan that we have? And where does it fit in terms of the funding requirements and the resources? So it's just a very complicated work, and I want to make sure we always work at a high enough level that we understand the strategic goals, priorities of those goals, and how we sequentially put these programs together.
This is Heather again, if I may. Raylene, I feel like that story you just shared is so important, and I'm sure it's not the only example. And that's something I just want to offer as kind of a struggle I've been thinking about lately, is that we have asked our criminal justice system to be the safety net for many people. And there are actually some success stories of people who have ended up in the criminal justice system who then get access to resources, like our drug court, right, is a great example. And it sounds like your story, right? This gentleman got access to some mental health support. And I feel like there's this transformation piece of, do we want the criminal justice system to be the safety net? And why do we have to wait for situations to get that bad before resources are offered? And I know that's not always the case, but I just feel like we're in that trapeze moment of how do we rebuild the system and shift so that people don't have to end up getting arrested in order to get the help that they need. And I think your point is really well taken, and I think a good reminder, refreshing on what is our continuum of care and what is our community's strategic plan, particularly for behavioral health, because there is an amazing plan. And I think sometimes, in all these conversations, we're not always tracking and remembering that there's a whole scope of investments, and there's so much work being done on the prevention side so that people don't end up in the criminal justice system. But even so, we still have people ending up in the criminal justice system. And do we want to wait to offer resource, or is there another way to intervene before they get arrested and end up in a courtroom?
Thank you, Heather. Any other comments or questions from anybody else? All right, that was a lot to think about. And hopefully we get more information as time goes on. Thank you, Anne, for all the information. You kind of get bombarded all the time. So I really do appreciate your assistance in these topics. The next item on the agenda is reentry. I think we need to not only look about reentry from the jail, but also from the prisons and how that's going to work on it, how we deal with both of those. And what reentry is actually happening, if there's impacts from the Blake decision, if we're seeing people actually leaving the prisons and the jails now because of that decision, or if we're still in a holding pattern. Maybe we can get some information on from Eric if you have anything on that. I'm going to let you guys take it from there, and I'm going to step away for just a minute and I'll be right back.
Eric, are you there? Doesn't look like it, huh?
No, I'm here. So
there
was
you
there
are.
a question directed to me? I mean, I heard that I was asked that I might have a comment, and I certainly will have a comment if somebody asks me a question. Go ahead.
Well, have you been involved with re-entry issues at all in your position?
Well, we certainly talked about a lot of things, and it's not exactly within the prosecutor's position, but we want to help facilitate those things. We're very concerned about it. So yeah, if there's something that we're working on, I'm right there with you. I think the question was really posed more about the Blake decision and whether that's impacting people being released. And the answer is yes. People are being released sooner than they were.
Right, but that's not answering it with reentry. They're just being released. Right. So I think my first question would be, what, if any, programs are actually operating at this time? Because we had a presentation from the Goodwill with their program, some months back, and it sounded like a pretty good program, but maybe not robust enough. But I don't believe that they are operating in the jails currently. Am I wrong?
So I think that's a better question for the sheriff. I think he can answer that question better than me.
Arlene, this is Stephen. I'd just like to reframe this a little bit. We've talked about reentry in a couple of forums over quite a while now, and often it's discussed in terms of what's happening in the jail. Have we replaced the half-time reentry person we had before? And to me, this is analogous to drug court, where if you provide treatment or resources and then you send the person into the same chaotic and unhealthy kind of environment afterwards, it's foolish to expect a very positive outcome. And to me, reentry probably requires more robustness after incarceration, a network of services and navigation supports than it does preparing to be released. But our conversations are always about that preparing to be released. And I just hope as we go forward in this, we broaden the scope of what we're thinking about as reentry. And first of all, we inventory what services would actually, in an evidence-based way, stabilize someone in returning to a productive community life.
No disagreements here. One of the things that was stated by the Goodwill providers was the significance of getting a job afterwards. The role that a job plays in a person's self-esteem, in their returning to any kind of normal existence is absolutely crucial. And the providers were saying that there were many more businesses that were willing to take people who have left the jails than we think. So, you know, that would certainly be an important piece, would be to have lists of employers who are interested in getting workers, but also there's the piece of training people to be on the job, following up on any kind of addiction or counseling services or medication services that are needed. And as you say, support people to assist this process to go on long enough to stabilize people. Currently, I understand that there are 2 counselors in the jail. I spoke to one of them, and that person said that they are trying to do their best to help with getting people ready, but now they have sort of, you could say, double duty. They're counselors, and at the same time, they're trying to help people prepare for discharge. So obviously that's not sufficient. I also encountered one other tiny program. I think it might've been through DVSAS, a small contract for coming for services, some counseling services.
Mike Parker.
Yeah, thanks, Raylene and all. So one thing to share. So I talked with our street outreach team leader and talked to them. You know, we obviously try to work with folks. We used to be able to go into the county jail and meet with folks. And obviously during the COVID, we haven't. So once things are safe, I think our street outreach team could be a piece of reentry, although that's not our only job. And we're working with unsheltered homelessness is a big one. But we know these folks, many of them will be reentering to homelessness. So obviously, whatever access we can have and support we can lend before people leave is really key. They highlighted a program to me, and I was curious about law enforcement's take on this, but it's ORCS, or Offender Reentry. I'm not going to say this acronym correctly, so let me look at my document here. But they're finding some folks with some good resources through ORCS, which can follow some folks. But it wasn't clear to me if that's restricted to developmental disabilities. And I was curious with folks that are either either associated with the jail or the sheriff. How useful is this Department of Corrections program, those services for individuals, and are we optimizing, or are we getting as much use out of it as we can here in Whatcom County? It sounds like it's a promising thing. It's actually still working even during COVID, and it has been very helpful for people. So that was my question part of it. The other part was the comment.
Mike, I can answer that in part, and I may not be fully updated, but when I used to manage the state prison for offenders with mental illness, I discharged or released the most people on that program simply because of my particular prison. It is very specific to a certain type of person, and no other offenders are eligible for it. And it provides money to the agency that is providing the supportive services upon release. Connection to treatment obviously is a huge goal, but it's very specific. It's defined in state statute who can receive those services. So I think what we have is what we have.
And Anne, was I not misspeaking that it's really targeted for those with developmental disabilities?
No, the primary issue has to be a serious mental illness.
Okay.
It could, co-occurring disorders obviously could be a part of that.
Okay.
It used to have another name. It used to have a horrible name. It used to be called DMIO, Dangerously Mentally Ill Offender Program. They were wise enough to change it, but.
From your description, it sounds like it might be more broadly applicable, but maybe I'm missing the specificity or the targeting from the WACs. I mean,
well, you have to meet certain criteria to be in the program.
Okay. So I guess in our community, for those that qualify, that has been a great asset. And so I think the question was, what would it look like if that could be broadened and that type of support, you know, could be extended. And then our other one is planning going forward for outside agencies that are interested in partnering with specialists inside the jail. What does the future look like for that? I mean, obviously we've had a lot of concerns about COVID and there's so many changes and I want it to be helpful, but I thought I would just kind of check in and see what folks are thinking in that arena.
I might just
so I can speak a little bit. Go ahead, Sheriff.
No, I was just going to add that COVID has really placed some limitations on our ability to perform some of the services. You mentioned Goodwill, and that was suspended during COVID. And I just got back in here after illness for a few weeks, and I'm not sure. I can't tell you today if that's been reinstated yet or not, or if that's in the hopper. But I can say that the population in the jail has fallen primarily due to the restrictions, booking restrictions, and the judges trying to help keep the population low and letting people out on their own recognizance and being more reluctant to sentence people to jail. That the population that we do have that's left, particularly in the downtown jail, is a very challenging population, is what I would characterize it. Not saying that it wouldn't be amenable. He described the Dangerous Mentally Ill program that the DOC runs, but we're seeing a different type of profile of inmates from those that are in there at the current time than we did just over a year ago.
Do you know what the percentage is, Sheriff Alpo, of people in the jail?
Percentage of?
You know, you say it's fallen.
Well, I mean, we used to run 240, 250, 260 in the main jail, and we're trying to keep it down to 110 inmates right now because we don't have the distancing. And the other thing is we're terribly down on staff to be able to safely ensure some of these programs are running. We're having difficulty, just as we are in law enforcement, in filling vacancies, and we still have 5 positions that are frozen in the county. So that also creates a limitation on us as well.
Thank you, Sheriff Alfo. I believe I saw Heather's hand and then Stephen Gockley.
I'm actually just wondering if we know what our current recidivism rate is and not even just for people that have been in our jail, but just people who are in the system and who've gone through court. And I asked that question because that helps us understand how well reentry services are working currently, and also would help us sort of target what reentry services we might want to consider investing in or building more of. So do we know what our recidivism rate is and the categories of what kinds of crimes are reoccurring, and whether it's more in that violent crime category or in the kind of crime of poverty or drug crimes related to addiction? Who has that data?
Well, I don't think that data really exists when we have 10 different court systems, and now the jail is not the place really. Most people that are arrested never make it to the jail. They're issued a summons, or we refer cases to the prosecutor to issue a summons or a citation. And so the systems don't talk to each other. Each agency has its own. So I think that'd be very difficult to measure. And I know there's another committee that's supposed to be solving that problem, and they have a big task ahead of them.
So I'll add that that's a great question. And you know, I'd like to be able to answer that for at least Whatcom County, because we should have that information. But, we've been struggling getting a case management system over the last 2 years. It's been approved by the county. It's been funded by the county, but it's been put on the back burner because, IT's been working on other COVID-related issues, trying to get people digitally able to appear in court and things like that. So it's been a real struggle. And as soon as we get a system that's we're able to access, able to get information from, we should be able to tell you what's going on in Whatcom County. But until then, I don't think we have that information for you.
So is it accurate to say that no reentry work is going on at the moment?
Arlene, I think I can respond to that a little bit. There is, as we touched base on, there's a jail behavioral health program that Compass Health has contracts with, and there are the two mental health professionals that you made reference to, and as Jackie had shared with the committee, that there's a vacancy in the reentry position for a period of time, and difficulties filling that specific individual's responsibility. However, the clinicians that are there communicate a pretty fair amount. I think that I've shared that I've stepped in as a interim mental health court program manager. Up until recently, we've hired a new program manager, and I have communicated with those individuals relative to some reentry navigation, I guess is the word that I'll use, as well as the ability to complete substance use disorder assessments. There are contracts currently set up to complete those assessments in the jail, as well as at least a portion of mental health assessments oriented towards engaging the individual in services at the point in time of their release. So from there, we oftentimes will utilize the resources that are available in the community, whether that's with Grace or with a community case manager from one of the community behavioral health providers, to walk with the individual to literally get them over to their intake appointment at Unity Care or CMAR or wherever it is that they're going to go. And so not extraordinarily formalized, but definitely in place, contracts in place as well. And certainly something that I've been using, as well as drug court uses to a certain extent, et cetera. And also needing further resources, certainly in terms of community case managers with the provider programs, in my opinion, as well as obviously an individual in the jail that's specifically responsible for the reentry process, preparing individuals and communicating with entities like the mental health court program manager or drug court program manager, those sorts of things. So I hope that helps a little bit.
So I'm going to add that LEAD is also working in that same area as Grace, helping people get to their appointments, helping people get to the proper courts, be it therapeutic or whatever else, and the other appointments that they need. And I know that they're assisting people who have been incarcerated and people while they're incarcerated. But it's probably not the true reentry program that we're all talking about and thinking that we need here. I'll tell you, I certainly support the idea of getting some more reentry programs here. But generally it's not my role. Although I'll do what I can if somebody helps me, helps direct me in the right place.
So it sounds like we have some coverage for a mental health care, some linkage for mental health care and for substance use, but not for case management issues at the moment.
You're now speaking to, at least from my experience, speaking to the gap that we have in behavioral health professionals in general. So it's true, and the community case managers, and I would very much agree with Mr. Ritchie that I've actually, reached out to Tommy McAuliffe and utilized some of that resource in a number of different ways, and they've been amazing in terms of response and support. But we definitely have a gap of community case managers in the community, generally speaking. And there's great need because they really carry a heavy load to literally, ensure the connection between the individual and that crucial time of leaving the jail and getting to that appointment, that's been scheduled and those sorts of things. So indeed, I would agree that we have a gap and we have a real need there in terms of those professionals.
Committee members, this is Jill here. I'm going to step in for a second. We have a number of hands raised. First, Stephen Gockley, and then Deborah Hawley, and then Moonwater. In addition, an attendee to today's meeting has her hand raised, Allison Batchelder-Bessel. If you guys would like to hear from her before the public comment period, please let me know and I can give her speaking privilege.
Jill, if we can go ahead and have Stephen and Deborah and Moonwater first, and then if we still have time before public comment, we can go ahead and let Allison in. Thank you.
Thanks, Eileen. My question arises out of the sheriff's comment about the very, very different characteristics of the current jail population from even a year ago. There is all sorts of analysis about what the world will look like when we come out of the pandemic, the economy, the labor market, all sorts of things. I'm wondering if whether the State Association of Sheriffs or prosecutors or public defenders, since Maya's on the call, whether there is any projection of what the arc of the composition of the jail population might look like 2 or 3 years down the road. Because I think given our common themes of limited resources and wanting to target most effectively the services that we assign with those resources, we ought to know who we would be serving, what reentry needs there might be a couple of years down the road. And I'm wondering what the common knowledge is in the field of how our jails might start to repopulate again as we work through backlogs of cases and start charging, lifting some booking restrictions, and so forth.
I'm unaware of anything that the Association of Sheriffs and Police Chiefs have done any research on that. But one thing that strikes me is the recent legislation that makes all drug possession charges misdemeanors rather than most cases felony offenses. That certainly will have some impact, because even as we ease up on booking restrictions, if we're able to do that, we're still not going to extend that to misdemeanors except in rare circumstances. I could say on the day that the Blake decision came out, we didn't have a single person in the jail that was solely in there on drug possession charges. They may have had drug possession, but other charges for which they were being held on. But that was an environment where the population was suppressed because of the restrictions that were attributable to COVID. So when COVID subsides, or if it subsides, I wouldn't anticipate we're going to start booking people for what the state has classified as a misdemeanor offense, given our resources that we have available and the problems with the building and the staffing.
Thank you, Sheriff Alpha. Deborah?
Yeah, can you hear me?
Yeah.
Can you hear me okay?
Yes, Deborah, go ahead, speak.
Okay. Okay, I don't know how to get my video on, so I apologize for that. I wanted to put out there to all of you that I am a great resource for answering questions on some of the topics that have been brought up, such as recidivism rates, and the fact that I am a representative on the task force as a consumer, meaning that my oldest son is a frequent consumer for decades of the system, both the prison system, Whatcom County Jail, and various other jails around the state. So I can answer a lot of the questions that I've heard the last 20 minutes or so, if anyone ever wants to direct these kinds of questions to me. But what I wanted to say is I'm a little bit behind in my research on such topics as recidivism, which I am most familiar with recidivism in the state prison systems. And the last time I checked, the rates were, and they're probably close to this, about 65% recidivism rate for people coming out of prison. I know our time is short, so I just want to make a couple of quick points that are very important. When somebody comes out of prison, as my son has 3 times, they are required by the Department of Corrections to return to their county of origin. So in the earlier discussion that some of you were having about reentry services and how the Department of Corrections and Whatcom County, as other counties, kind of run on parallel tracks, like they're not directly related, they don't really interact with each other. But to cut to the chase, what ends up happening so many times is that there aren't enough reentry systems by far, and the systems that are there are usually very ineffective for people like my son, who has a long-standing mental health disorder and a existing substance abuse disorder. Well, you've got somebody coming out of prison and they've returned to their county of origin. So in my case, my son's case, here he is in Whatcom County. And unfortunately, something has happened and it's not good. And so my son is in custody again. And it's just a vicious cycle that I've watched him and others go through of PTSD, coming out with PTSD or having it before they ever went in due to trauma in their lives. And then treating that PTSD with drugs, also treating their own mental health disorder with drugs. And then the cohabitation, with the people in prison isn't exactly conducive to great dialogues, although sometimes it can be. In other words, the criminal activity is somewhat being reinforced, or heavily reinforced, perhaps, is a better way to put it. I don't know if I've painted the picture or not, but it's kind of a big mess. And just one last thing, my experience with DOC is the last DOC probation officer that my son had here in Whatcom County was very nice and very helpful in certain ways. However, any of the things that I ever asked implemented and thought I had a court order from another court out of sight of Whatcom County for mandatory mental health treatment and mandatory drug treatment were never followed through. To conclude, the DOC officer gave my son an option. Do you want to do mental health treatment? Do you want to do drug treatment? And if he said no, well, that was the end of it. So there weren't very strong parameters, and I'll stop there.
Raylene, I hate to interject. As one of your co-chairs of the meeting, I know we're not going to get to all of our agenda items today. I just wanted to cover very briefly, and my apologies, I can't stay late today. I do have an appointment, and I just want to honor everybody's time. I also wanted just to highlight to other members, and I do apologize the intrusion. If you're waiting to speak, I apologize. There are a couple items from the Behavioral Health Subcommittee, which we are not going to get to today, but I wanted to just really quickly touch base on, I think we've kind of touched base a little bit on the workforce shortage, so at number 5 on your agendas. Number 6, which is making funding recommendations to county council. If you all do stay, I think I had a conversation with Ann Deacon about that. And our understanding in the Behavioral Health Subcommittee, by the way, is that we're really not making funding recommendations per se, so I probably wouldn't have termed it quite like that. So what I'd like to say is that we understand, one, as committee members, we have ways to advance, like highlighting a program or a specific need. And I hope, Jill, maybe we could share the form with folks so that this group would also be exposed to that kind of methodology. So if we think there's something worthy that the county council or health department or any other area should take under advisement for funding, we have a process to do that. And the other piece I just wanted to add about that, Raylene, very briefly, and then I'll stop talking, was that there's a behavioral health advisory committee, and I think also Ann Deacon has more information about that. So should committee task force members have recommendations, I think we've got a good target to be able to pass that on, and I think we might look at making that more formal, but we certainly want to highlight that capability to task force members of existing committees that kind of look at that. And just in deference to Ann's comment that, that Behavioral Health Advisory Committee is kind of the holder of the continuum, so to speak. So if we want to weigh in as task force members or as a subcommittee, we've got some methods to do that. Apologies that we didn't get to the agenda. I really do think it was a really good discussion though. And Raylene, I don't know about you and Arlene, but I didn't want to stop it. But I do apologize for not making all of our agenda topics. And I think we may have to hit some of those another time. Thanks.
Thank you, Mike. I really appreciate you actually breaking in there because I was concerned. I'm looking at the time, watching it go by and by, and everything is very important, and I didn't want to stop it either. I think one of the items that was going to hit other business, which I don't want to leave out, was that the discussion came up about possibly having another behavioral health, legal and justice rather than the 2 per year, because we have a lot of overlap. So that we can kind of divide some of these items and determine what areas legal and justice can focus on, what areas behavioral health focuses on, and what areas we need to work together on. So some of those topics, maybe we can separate them out if we can try to schedule another meeting on that area, and maybe Jill can help us. Domestic violence is definitely something I wanted to speak about because it was also something Bellingham Councilmember Hamill had brought up that was near and dear to his heart, but we're not going to have time for that, obviously. And I wanted to make sure Bruce Van Glump or Jake Weebush from probation were also involved in that, and Carol Donovan with domestic violence victims for the small cities. I wanted to make sure she was available so we can table those items. And then discuss possibly having another joint meeting. And then I think there was a public comment. And Jill, am I missing anything else?
No, that's all. Thank you.
Moonwater, you have your hand raised.
I just briefly wanted to speak to the reentry piece. One quick thread just to plant a seed is that we've long talked in the Legal and Justice Committee about the possibility of navigators joining up with people as they enter jail and through a case management lens, supporting them throughout their time in jail and then supporting their reentry. And I don't know that that idea has ever taken hold with any particular committee, department, or group of people. So I just wanted to replant that seed. And then I'll also email to you, Jill. I just noticed a quick look on the statewide Reentry Council's website that they issued a report in December of 2020 with some key overarching goals that might be of interest to our shared committees as a framework for thinking about how those statewide goals and priority areas trickle down to what we're doing here in Whatcom. So maybe that could be a guiding document for us to at least look at and help us organize our thinking about reentry. And then when we do talk about domestic violence treatment, I did follow up with DV-SAS and the DV Commission, and I'll just briefly acknowledge that my understanding from both directors is that due to a variety of reasons and lots of transition happening, there's no activity happening within those organizations right now of moving forward with perpetrator treatment at this time, but interest down the road.
Thank you, Moonwater. Also a question for Eric Ritchie and Darlene Peterson on the reentry. This might come back to a law and justice meeting, but I was hoping that maybe the three of us could get together on a warrant amnesty based on some of the comments from Sheriff Elfo and booking restrictions, and with COVID that might be something we want to look at least from the Legal and Justice Committee team. And any other questions, comments, or we go to public comment?
Yes, before we sign off, I'd like to thank Deborah for sharing today. And I know that must have been really hard to talk about the things that she did. And the input that she provides this community is so important. And I just wanted to let her know how much we appreciate her.
So if we're moving on to public comment, we have one attendee today with her hand raised. Allison, I'm going to go ahead and allow you to speak. Go ahead and unmute your microphone, and you can speak to the committees now.
Hi, thank you for giving me a little bit of time. My name is Allison Batchelor-Vesley, and you may know that I spent 10 years doing the reentry in the jail. And I just wanted to let you know my presence in case you had any questions, which you're going to have to do at some other time. But I'm sort of doing the proxy work for Byron Mannering out of Bridget Collins. So I am watching these meetings if you have any questions. And we do have a tiny reentry program at Bridget Collins with a caseload of 6. So we do have, and we are working with reentry but these are parents. We can only do people who are parents, which was unlike the reentries in the jail, which was mental health people. So just want to throw that out there, and thank you for listening to me.
Thank you so much, Allison. I really appreciate you letting us know you're out there for us.
Thank you, Allison. If either of the other 2 attendees would like to speak to the committees, please virtually raise your hand now. And no hands are raised.
Any final words from any of the other members? Thank you, everybody, for your assistance today. This meeting is adjourned. It is 1:04 p.m. on May 11th.